tackle 14 and 15 today. Um, right at the end of the book, um, we talked about 16 last time, so we're going to go ahead and get started. Maybe. There we go. Okay, eating, sleeping, and elimination disorders. The dysfunctions examined in this chapter all involve basic biological processes necessary for human life. Eating, sleeping, eliminating waste. Many of the conditions involve the patterning of the activity, although symptoms of excess and deficiency are diagnostic. DSM-5 lists 6 feeding and eating disorders: anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant and restrictive food intake disorder, pica, and rumination disorder. Obesity is not currently defined as a mental disorder. The first described and named by doctors in Paris and London in the 19th century, we're talking about anorexia nervosa. It appears to have been exceedingly rare until the mid 20th century, when its incidence increased, particularly in Western industrialized countries, and that W should be capitalized. Involves 3 main features: restricted caloric intake, insufficient to maintain normal body weight, intense fear of gaining weight, disturbance in the perception of body size. 2 eating patterns are characteristic. Restricting type, the individual diets, fasts, or exercises excessively so that intake of food is inadequate to maintain current weight. Binge eating purging type, the individual regularly consumes food, often in large quantities, but then compensates by engaging in practices to produce weight loss. This type is less common. Anorexia nervosa involves subnormal weight given the person's height and age. Most often, weight loss is achieved by severe restriction in diet. Typically, food becomes a preoccupation for those with anorexia nervosa, often with obsessive compulsive intensity. Onset usually occurs in adolescence, and the course is highly variable. Many who begin with the restricting type of this disorder shift to binge eating purging type within the first 5 years. In females, menstruation often ceases or is delayed in prepubertal females. Hospitalization may become necessary, and mortality may be up to 5% per decade. The incidence of anorexia nervosa is much higher among young females in Western industrialized nations where food is plentiful. Anorexia nervosa appears to be linked to cultural views about beauty and thinness and is driven by widespread media representations of increasing thin models as images of perfection in fashion. Lifetime prevalence rates now appear to be about 0.9% for females and 0.3% for males. Male cases tend to be associated with homosexuality. Those at highest risk are white females aged 15 to 24 years. It appears to be extremely rare among African American females. Commonly occurs in conjunction with other mental disorders. The etiology of anorexia nervosa remains unknown. It runs in families, and concordance rates are higher in monozygotic than dizygotic twins. Strong association with cultural portrayals of beauty in terms of thinness also indicate very important contributions from environmental factors. Certain athletes, especially those involved in aesthetic performance or those emphasizing a specific weight, are at higher risk. And what we're talking about is gymnastics, swimming, um, what, figure skating. Outcome of treatment of anorexia nervosa did not improve much throughout the 20th century. Even after 1950, mortality remained significantly high, averaging 5%, but ranging up to 22% in some studies, and less than half the patients fully recovered. Some promising results have been reported for a particular form of conjoint family therapy for adolescents in which parents are coached in how to assume control over the anorexic child's eating and weight. This approach is less beneficial with older persons or if the disorder has persisted beyond a few years. No drug has been found to promote weight gain for these patients. The addition of medication does not add to outcome, and at present, there is no specific role for pharmacology in the treatment of anorexia nervosa. Inpatient treatment, which allows for close monitoring, nutritional counseling, and specific behavioral contingencies, can be effective. Bulimia nervosa involves a sense of lack of control related to recurrent episodes of eating large quantities of food, binge eating, and subsequent purging. Binge eating involves amounts of food larger than others would normally eat in a given time, usually includes high calorie foods such as cookies, cakes, and ice cream. Between 1,000 and 2,000 food calories are typically consumed during the binge event. Usually it takes place rapidly in secret and continues until the individual becomes uncomfortably full. The person often reports feeling out of control. Bulimia nervosa is more common than anorexia nervosa, affecting up to 1.5% of females. The female to male ratio was 10 to 1. Most receiving the diagnosis are white. Onset is usually 5 years later than that for anorexia nervosa, and the average duration of the disorder much longer, about 8.3 years. It may persist for several years, but over the longer term, symptoms tend to diminish. Bulimia nervosa is not related to the socioeconomic status of the individual. Risk is elevated among victims of childhood physical or sexual abuse. Studies have suggested heritability estimates between 50 and 83%. Clinical studies show 35% concordance in monozygotic twins versus 30% concordance in dizygotic twins. It seems to indicate a weaker genetic link than for anorexia nervosa. Cultural factors affect one's tendency to relate body image to self-esteem, and bulimia nervosa are assumed to be similar to those of anorexia nervosa. As thin beauty ideals are unattainable for nearly everyone, negative self-effect develops, leading to dieting and restriction, which then increases the chance that binging will occur in response to severe hunger. Outcome data for those with bulimia nervosa are more promising than that for anorexia nervosa. Evidence supports the use of both medications and psychotherapy. The treatment of choice is cognitive behavioral therapy. About half of patients cease binge eating and purging. Antidepressant medications produce improvements in both binge eating and purging over placebos, but not as great as cognitive behavioral therapy. Binge eating disorder includes recurrent episodes of binge eating associated with both a sense of lack of control and rapid consumption. Diagnosis requires that binges average at least once a week for a 3-month period. Must be associated with marked distress. I'm having trouble saying associated for some reason. Binges are not accompanied by compensatory behaviors, and as such, the condition is frequently associated with varying degrees of obesity. Eating patterns tends to be chronic and is often associated with depression, anxiety, and negative self-image. Binge eating disorder may not appear until well into adulthood. The condition is not linked to racial ethnic status. The DSM-5 provides 12-month prevalence rates at 1.6% for adult females, 0.8% for adult males. Binge eating disorder appears to be different from related patterns of disordered eating, night eating syndrome. In the DSM-5, this would be diagnosed as other specified feeding or eating disorder. In night eating syndrome, individuals consume more than half of their daily calories and late night binges. Cognitive behavioral therapy is generally associated with high treatment completion rates, remission of binge eating in over half of subjects, and improvement in accompanying depression. Antidepressant medications are superior to placebo in reducing binging and weight. Relapse rates are high and discontinuation of treatment is problematic. Those with avoidant restrictive food intake disorder do not eat enough food to meet their energy or nutritional needs. Unlike anorexia nervosa, the lack of appetite or avoidance of food does not involve body shape or image. This new DSM-5 diagnosis replaced the DSM-4 condition, feeding disorder of infancy or early childhood, which required childhood onset. Oops. Infant feeding disorder may account for half of hospital admissions for failure to thrive. It may have community incidence of 3%, appears to be equally prevalent in males and females. The avoidance of restriction of food might be attributable to Pavlovian conditioning. An aversive experience may be paired with particular food-related stimuli. The avoidance of food may emerge as an anticipatory conditioned response, sometimes termed functional dysphagia. Pica essentially involves a persistent, for at least a month, eating of non-nutritive substances such as soil, paint, cloth, string, insects, and pebbles. Eating these substances must be inappropriate to developmental level and not be a culturally sanctioned practice. Typically, the condition remits after several months or a few years. Pica is more often found in association with intellectual disability, where its incidence can be as high as 15%. In rumination disorder, individuals repeatedly regurgitate their food and either discard it or, more commonly, rechew it. The condition must persist for a month and not be associated with a general medical condition or other eating disorder. Rumination disorder usually occurs in infants with onset before 1 year of age. Some older individuals with intellectual disability may also show the condition. Rumination disorder appears to be rare. Disturbances of sleep in the DSM-4 were described as dysomnias, conditions involving abnormal sleep amount, quality, or timing, and parasomnias, concerned with abnormal events or behaviors involving the sleep cycle or sleep-wake transitions. In the DSM-5, these distinctions are no longer central to the organization of the sleep-wake disorders, but they retain their descriptive value in the discussion of the disorders. Sleep-wake disorders can cause significant life impairment similar in degree to chronic health conditions like diabetes, heart disease, or arthritis. Correct diagnosis may be difficult, requiring extensive information about history and evaluation in a sleep laboratory. Because sleep patterns are so variable and symptoms are so common, the prevalence of most sleep disorders is uncertain. Difficulty falling asleep or remaining asleep or unable to get back to sleep after early morning wakening, this is insomnia disorder. Complaints of non-restorative sleep and daytime fatigue. To qualify, the condition cannot be due to general medical condition, the effects of a substance, or another mental disorder. Insomnia disorder must persist for at least 3 months, occurring 3 nights per week, and cause significant distress or impairment in functioning. It can be specified as being comorbid with non-sleep mental disorders, other medical disorders, or other sleep disorders. Specifiers are also provided to indicate if the condition is episodic, 1 to 3 months of symptoms, persistent, more than 3 months of symptoms, or recurrent, 2 or more episodes within a year. Insomnia disorder is the most prevalent sleep disorder. 1/3 of adults complain about insomnia, Perhaps 10% of the population and 25% of the elderly population would meet the diagnostic criteria for insomnia disorder. The disorder occurs more often in women, often following the birth of a child or menopause. The course is variable, but over half the people with chronic complaints of insomnia continue to experience symptoms for more than a year. Problems with disrupted sleep runs in families. Psychological distress is the most common cause of insomnia disorder. If the disruption continues, the person becomes frustrated, anxious, and concerned about his or her inability to sleep, increasing the emotional arousal and further interfering with sleep. Individuals often attempt to force sleep by remaining in bed longer, but that serves to associate the bed with arousal and wakefulness. And of course, this is a form of Pavlovian conditioning. Benzodiazepines are widely used, but not recommended for long-term use. Pharmacotherapy degrades over time. Melatonin has been shown to improve sleep in chronic insomniacs with few side effects and no withdrawal symptoms. Non-pharmacological interventions include stimulus control, restricting use of bedroom to sleep-related activities only, sleep restriction via a regular sleep-wake schedule without napping, relaxation training, and a control of stimulants such as caffeine. Regular exercise not close to bedtime is also helpful. Hypersomnolence consists of excessive sleepiness despite receiving at least 7 hours of sleep during the main sleep period. These individuals may sleep for more than 9 hours without finding it refreshing, then have difficulty awakening. Daytime naps are not experienced as restorative or refreshing. Unintentional sleep may occur. In one type of recurrent hypersomnolence disorder, Klein-Levin syndrome, individuals may spend as much as 20 hours per day in bed. Hypersomnolence specifiers include comorbidity with another mental disorder, medical condition, or sleep disorder. Duration specifiers for acute, less than 1 month, subacute, 1 to 3 months, and persistent, more than 3 months. Severity indicators for mild alertness difficulties, 1 to 2 days per week, moderate alertness difficulties, 3 to 4 days a week, and severe alertness difficulties, 5 to 7 days a week. Mood disorders and substance dependence related to stimulant use may be more common among those with some hypersomnolence. Prevalence for males and females is approximately equal. Onset is usually between ages 15 and 30, and the course tends to be chronic and stable, sometimes for decades. Incidence is about 1% of the population. As many as 10% of individuals at sleep clinics complain of hypersomnolence. Narcolepsy is repeated, irrepressible sleep occurring at least 3 times per week for at least 3 months. Sleep is unintended and may occur in inappropriate situations. In addition to sleep attacks, the diagnosis requires either cataplexy, a deficiency of hypercretin, or short latency, 15 minutes or less, to REM sleep. Cataplexy is often precipitated by strong emotions such as anger, laughter, or surprise. Joking and laughing are the most typical triggers for cataplexy. It can range from subtle signs that may not be obvious to others, such as drooping eyelids or a sagging jaw, to dropping items and falling to the ground. Full consciousness is maintained during the episode, typically lasting only a few seconds or minutes. A significant proportion also experience REM intrusions, which produce vivid dreamlike imagery just as one is falling asleep. hypnagogic hallucinations, these are referred to as, or just after awakening, hypnopompic, hypnopompic hallucinations. Also results in sleep paralysis in nearly half of those with narcolepsy. Hypnagogic and hypnopompic hallucinations occur in about 15% of the general population, and up to 50% have experienced sleep paralysis, making these REM-related symptoms not unique to narcolepsy. Typically experience, this is narcolepsy. They typically experience sleepiness daily. 2/3 have fallen asleep while driving. Narcolepsy is quite rare, 0.04% of the population or less, and slightly more common among males. Affected individuals may also have a history of mood or anxiety disorders as well as obesity. Up to 1/2 of first-degree relatives of those with narcolepsy also show symptoms of sleepiness, and up to 15% have the disorder, suggesting a strong genetic contribution. First-degree relatives of those with the disorder have been calculated to be 75 times higher than the general population. However, monozygotic twins have high non-concordance rates, indicating unknown environmental contributions to the disorder as well. Cause of an association with specific patterns of human leukocyte antigen response. Some have proposed that narcolepsy may arise as part of an autoimmune condition. Manipulation of genes controlling production of hypocretin can produce narcoleptic states in dogs and mice, and there is a deficiency of hypocretin in the spinal fluid of some narcoleptics. It may be due to an autoimmune-related loss of neurons in the hypothalamus that produce hypocretin. Therapeutic naps for 10 to 60 minutes daily may be of benefit in management of narcolepsy. Stimulant drugs are typically used to stave off sleep attacks. Methylphenidate is the preferred drug for preventing sleep onset. That's Ritalin. Antidepressant medications may help reduce cataplexy in patients with narcolepsy. The central feature of breathing-related sleep disorders is sleep disruption, leading to excessive sleepiness or insomnia caused by a breathing difficulty. There are several symptoms of breathing-related sleep disorders: sleep apnea, breathing ceases during sleep; hypopnea, unusually slow or shallow breathing; hypoventilation, abnormal blood levels of oxygen and carbon dioxide. People with breathing-related sleep disorders, as well as those with hypersomnolence disorder, sometimes experience a dull headache on awakening, and sometimes accompanied by sleep drunkenness or sleep inertia, difficulty wakening, confusion, and inappropriate behavior. Mood and anxiety disorders are often associated with breathing-related sleep disorders, significantly less common in children who are breastfed for at least 2 months. Obstructive sleep apnea hypopnea is the most common form of breathing-related sleep disorder. Obstructive sleep apnea hypopnea involves repeated obstructions of the upper airway accompanied by loud snoring. DSM-5 diagnosis requires at least 5 apneas or hypopneas per hour of sleep, verified by polysomnography, resulting in nocturnal breathing disturbance, daytime fatigue, or evidence of 15 or more apneas or hypopneas per hour, regardless of symptoms. Obstructive sleep apnea hypopnea can be specified according to severity based on the degree of reduced blood oxygen saturation. Obstructive sleep apnea hypopnea can be specified according to severity based on the degree of reduced blood oxygen saturation. Obstructive sleep apnea hypopnea is more common in overweight individuals. Soft tissues in the neck can block the airway, and those with large necks over 16 to 17 inches are at greater risk. In less obese persons, obstructions can be related to tonsil size, abnormal growths, or nasal airway obstruction. Obstructive sleep apnea hypopnea occurs in up to 15% of the adult population, with higher rates more than 20% among the elderly. Obstructive sleep apnea hypopnea tends to have a gradual onset and a chronic course. It can contribute to premature death by heart arrhythmia or cardiovascular disease. Weight loss and continuous positive airway pressure or other techniques to keep the airway open are the most effective treatments. We're talking about a CPAP machine. Central sleep apnea is a much rarer breathing-related sleep disorder is central sleep apnea, in which there are 5 or more apneas per hour of sleep not related to obstruction. The periodic breathing patterns can be subtyped as idiopathic, comorbid with opioid use, which impacts respiratory rhythm, or related to Cheyne-Stokes breathing and decreasing air intake pattern tied to the development of heart failure. Cheyne-Stokes. Sleep-related hypoventilation involves shallow or decreased breathing that, that leads to elevated levels of carbon dioxide in the blood. Sufferers of sleep-related hypoventilation complain of frequent awakening, sleepiness, insomnia, and headaches. Thought to be uncommon, sleep-related hypoventilation may be increasingly related to rising obesity and chronic obstructive pulmonary disease, COPD rates. Circadian rhythm sleep-wake disorders involve a persistent sleep disturbance due to a mismatch between the person's internal 24-hour sleep-wake cycle and the schedule required by the person's environment. There are a number of types associated with these disorders: delayed sleep phase type, advanced sleep phase type, shift work type, irregular sleep-wake type, non-24-hour sleep-wake type. Delayed sleep phase type, there is a great difficulty shifting the sleep-wake cycle forward, but once sleep is initiated, it is normal. Individuals feel continually sleep deprived due to the need to maintain social or occupational obligations, except on weekends or during vacations, when they tend to shift back to a later cycle. Advanced sleep phase type, earlier sleep onset and awakening with the inability to adjust to the conventional later sleep-wake times. Shift work type may be the most common among those on night shift or rotating shift schedules. Shorter sleep duration and more frequent awakenings, often accompanied by difficulties pertaining to family demands and environmental disturbances during sleep times. Severity of circadian rhythm sleep-wake disorder appears to be increase with age. Some forms, for example, shift work type, show reversal of symptoms with schedule changes, while the delayed sleep phase type may last for decades. Prevalence is unknown. More than 7% of adolescents may experience delayed sleep phase type. More than 10% of night shift workers may experience shift work type. Some types appear to aggregate within families. Melatonin appears to be beneficial in treatment. The DSM-5 diagnostic category is a combination of 2 separate DSM-4 disorders: nightmare disorder and sleep terror disorder. We're talking about sleep arousal disorders. It involves incomplete awakening from sleep, accompanied by sleepwalking or sleep terrors. Usually, the incomplete awakening occurs in the first third of the sleep episode and tends to be brief, less than 10 minutes, although no longer up to 1 hour events may occur. The, in both sleepwalking and night terrors, persons do not remember the event the next morning. Sleepwalking involves repeated episodes of complex motor activities such as rising from the bed and walking about, which begin during slow-wave non-REM sleep. Episodes may last a few minutes, up to a half an hour, and usually terminate in return to full sleep, sometimes in new or unfamiliar locations. If awakened, which is difficult, the sleepwalker is typically confused for several minutes and does not report dreaming or awareness of the event. There have been reports of complex sexual or violent behaviors including homicide and rape, occurring during episodes of sleepwalking. Sleep-related violence may be greatly underreported, with as many as 2% of the population enacting some form of violence during sleep. Sleep-related eating may also occur during sleepwalking episodes, especially among females with varying degrees of amnesia. Individuals with sleep terrors awake from sleep abruptly, usually with a cry or panicky scream, and are generally unresponsive to efforts to awaken them. If they fully awaken, they do not recall dreaming apart from fragmented images and a sense of terror. Episodes recur after several days or weeks and are made more likely to by fatigue, stress, and alcohol or sedative use. Usually non-rapid eye movement sleep arousal disorders begin before age 12 and resolve during adolescence, thereafter declining from an incidence of perhaps 5% among children to less than 1% in adults. Especially in adults, sleep terror is related to higher incidence general psychopathology, including PTSD and mood and anxiety disorders and some personality disorders. A family history of sleepwalking or sleep terror is present in up to 80%. Repeatedly experiencing frightening dreams that results in awakening. We're talking about nightmare disorders. Most often nightmares involve threats to one's safety, security, or self-esteem, and or the sleep disruption they produce. Significant distress or impairment is caused. Dreams usually last longer than 10 minutes and happen during REM sleep. Most often occurs in children who have been exposed to severe psychosocial stressors. Dreams usually begin between 3 and 6 years of age and increase in prevalence and severity into early adulthood. Females experience nightmare disorders up to 2 times more often than males. Nightmare disorder most often occurs in children who have been exposed to severe psychosocial stressors. The dreams usually begin between 3 and 6 years of age and increase in prevalence and severity into early adulthood. Females experience nightmare disorder up to 2 times more often than males. Some consider PTSD a predisposing factor. Incidence is unknown. Rapid eye movement sleep behavior disorder was elevated to a parasomnia in the DSM-5. It involves complex motor activity occurring during REM sleep and associated with vivid dreaming. Normally, skeletal muscles are paralyzed during REM sleep, but in those with REM sleep behavior disorder, that paralysis is absent, allowing people to essentially act out their dreams. Rapid eye movement sleep behavior disorder may precede or accompany the development of some neurodegenerative conditions, including Parkinson's disease, and may be more likely in children with autism. Prevalence is about 0.5% of the population. Rapid eye movement sleep behavior disorder can be induced by a variety of medications, including antidepressants. Causes remain uncertain. Most commonly treated with benzodiazepine medications. Restless leg syndrome has been elevated to a parasomnia with provisional status in the DSM-4. Restless leg syndrome involves frequent urges to move the legs, especially when resting, in order to relieve unpleasant sensations such as itching, burning, or tingling. Urges are worse in the evening or night and partly or totally relieved by movement. Symptoms for restless leg syndrome must occur 3 times per week for 3 months to qualify for the diagnosis. Between 2% and 7.2% of the population may be affected. Sleep-related limb movement disorder, including restless leg syndrome, increase with age. The incidence increases up to about age 60, and the disorder is more prevalent in females, especially during pregnancy. Substance medication-induced sleep disorder describes the many sleep dysfunctions that can be caused by substance use, intoxication, or withdrawal. Older individuals who take multiple medications may be at greater risk. Women seem more susceptible to substance medication-induced sleep problems than men, given the same amount and duration of consumption. Only 2 elimination disorders are listed in the DSM-5, encopresis and enuresis. It must be distinguished from developmentally appropriate deficiencies in toileting abilities in young children. It's not diagnosed until after the normal period of attaining continence. The repeated passage of feces by a person over the age of 4 into inappropriate places is encopresis. Events which are usually but not always involuntary must occur at least once a month or for at least 3 months and are not due to general medical conditions other than constipation and its mechanisms or the use of laxatives. Usually the pattern of encopresis consists of constipation followed by impaction, further retention, and overflow incontinence. Encopresis may affect 1% of 5-year-olds and is more common among males. It's voluntary or intentional. It may be associated with conduct disorder or oppositional defiant disorder. Treatment may involve high-fiber diets, use of laxative, relaxation training, and behavioral interventions that shape and support regular patterns of toileting. Enuresis is repeated voiding of urine into the bed or clothes during day or night in children aged 5 years or older. The condition is not due to a general medical condition and must occur at least twice a week for 3 months. The diagnosis can be subtyped as nocturnal, diurnal, or both. Most children with enuresis become continent by adolescence. Prevalence may be 10% among 5-year-olds, but falls to half of that by age 10. Only about 1% of cases continue into adulthood. It has strong familial patterns. Offspring of an enuretic parent have 5 to 7 times the risks as the general population for developing enuresis. 75% of children with the disorder have a first-degree relative who was affected. Treatment, oral medications such as antidepressants and desmopressin, a synthetic urine suppressor, are more effective than placebo in reducing enuresis, but relapse is likely when medication is discontinued. Behavioral approaches have involved attempts to condition children to respond to the sensation of a full bladder, and their effectiveness is well validated. The bell and pad method is the best known technique. It's effective in 75% of cases. As soon as the pad gets wet, a bell rings. And that is the end of chapter 14. So let's go ahead on to chapter 15. Neurocognitive disorders. This is normally for people that are older. Delirium, dementia, and amnestic disorders are categorized as organic mental disorders by the DSM-3, reflecting their evident connection to brain pathology. As all mental disorders have organic or physiological components, the phrase organic mental disorders was dropped from the DSM-4. The DSM-5 retained the classification for delirium disorders and combined the dementia and amnestic disorders into the classification of mild or major neurocognitive disorders. In the DSM-4, it was important to distinguish conditions that involve some degree of memory dysfunction from the effects of normal aging. In the DSM-5, these symptoms, whether normal aging or not, are now included under the new diagnosis of mild neurocognitive disorder. In the DSM-5, any physical disease that accompanies symptoms is coded along with the mental disorder. Many pathological conditions of the brain are more common in older persons. Prevalence of dementia is highest in those over age 85. Compromise of brain function and its psychological effects can occur at any age, resulting from factors such as disease, injury, tumor, inflammation of the brain, encephalitis, or a drug or toxin. Some of these conditions are progressive, with continuing decline in cognitive function for the remainder of life. Other conditions are transient and may resolve rapidly and completely. If the underlying organic cause is resolved, the cognitive decline may cease or reverse its course. The nature of the psychological impairment produced by the brain dysfunction is related to the area of the brain that is affected. Although the degree of localization of particular cognitive and emotional activities has often been overstated, some broad psychological functions are integrated in specific parts of the brain. And there you go. All the fun parts of the brain. Specific language difficulties can be produced by left hemisphere cortical damage. Damage of Broca's area produces Broca's aphasia, which involves effortful, slow articulation with little information included. Damage to Wernicke's area produces Wernicke's aphasia, which involves fluent speech that conveys little meaning and a profound deficit in comprehension of another's speech. Neglect syndrome is a type of spatial dysfunction in which one side of the visual field seems to be ignored. Most often seen with the left visual field and caused by damage to the right parietal lobe. Damage to the right parietal lobe is frequently accompanied by relative unconcern on the part of the patient. Patients with less left hemisphere damage, in contrast, tend to show strong depressive reactions to their conditions. And this is neglect syndrome due to damage to the right parietal lobe. As you can see, they are not drawing the left half of things because the right side of the brain isn't acknowledging it. So here's a clock, and it only has time on one side. And here's a flower, and of course they didn't draw petals on the left side. Delirium, the DSM-5 organizes delirium diagnosis according to etiology. Major and mild neurocognitive disorder, the DSM-5 organizes the former dementia and amnestic disorders into these categories, also organized according to etiology. Delirium is a change in consciousness that can involve disorientation, impairment of usually recent memory, illusions or hallucinations, and reduced attention to the surrounding world. Delirium develops rapidly and can fluctuate in severity throughout the day, typically becoming worse at night. There must be evidence that the disturbance is related to a specific psychological cause, such as a medical condition, a medication, or a substance. Delirium describes a relatively brief but global cognitive impairment of attention. Delirious individuals are often not oriented to place or time, Motor activities can vacillate, shifting between hyperactivity and lethargy. Shifting emotional disturbances are typical, including extremes such as euphoria, anger, and depression. Fear is commonly present. These emotional, perceptual, and speech disturbances can resemble other psychotic conditions. They are delirious because of their fragmented and fluctuating presentation. Delirium usually follows an acute course, developing within hours or days and most often resolving within weeks or more rarely months. Delirium may affect between 1% and 2% of the general population, associated with increased risk of mortality. Nearly 40% die within a year of diagnosis. Over half hospitalized patients display delirium. 83% of people develop delirium at the end of life. Delirium can occur in all ages, with children at increased risk, especially during illnesses involving fever. Advancing age, male gender, alcohol abuse, dementia, and sensory impairment are other risk factors. Delirium can be caused by exposure to toxins, including fuels, solvents, insecticides, and carbon monoxide, by medications, drugs of abuse, physical damage to the brain, and a host of other events. If the reaction during drug ingestion is significantly different from normal intoxication, resulting in cognitive impairment that is excessive and serious enough to warrant clinical attention, then a substance-induced delirium, e.g. alcohol intoxication delirium, may be diagnosed. Besides alcohol intoxication, delirium is associated with amphetamines, cannabis, cocaine, hallucinogens, opioids, PCPs, sedatives, anxiolytics, or combinations of drugs and substances. In most conditions, delirium resolves within a few hours or days as the intoxication dissipates. Substance withdrawal delirium involves cognitive disturbances in excess of those normally accompanying withdrawal and serious enough to warrant clinical attention. Substance withdrawal delirium has been identified for alcohol, the DTs, as well as delirium tremens, as well as the sedative, hypnotic, or anxiolytic drugs. Substance withdrawal delirium usually runs its course in days. In some longer-acting substances, withdrawal delirium can persist for weeks before resolving. Many medications or their side effects can also cause delirium, including anesthetics, analgesics, antihistamines, muscle relaxants, heart medications, and some psychotropic medications such as lithium. Especially among the elderly, polypharmacy is a major risk factor for substance-induced delirium. Almost 44% of frail geriatric patients in a recent investigation of delirium prevalence were receiving more than 8 regular medications daily. Delirium can develop in the context of a wide range of medical conditions. The specific medical conditions, such as infection of the brain, a stroke, low blood sugar, or a tumor, is noted in the diagnosis, for example, delirium due to head trauma. Because many of the medical conditions that cause delirium can be treated, delirium due to a general medical condition is frequently resolved rather than quickly by interventions for the underlying condition. Delirium due to multiple etiologies can be diagnosed if more than one specific physical factor is known to be involved in the cause of the delirium. For example, delirium might result from the combined effects of a liver disease and substance withdrawal. In the elderly population, medication side effects frequently interact with physical disorders, both of which contribute to delirium. Most people recover fully from delirium, whether they receive treatment or not, but intervention shortens the course of disturbance. Treatment of the florid and even psychotic symptoms often involves sedation, usually via low-dose antipsychotic medications. The cognitive disturbances associated with neurocognitive disorders involves cognitive decline in one or more cognitive domains. In contrast to delirium, mild and major neurocognitive disorders may have a gradual onset and more frequently a chronic course. In the DSM-4, this disorder was known as dementia. Dementia always involves a memory deficit, which is most apparent in recent memory and the retention of new learning. When advanced memory impairment extends beyond recent events, and people may forget important personal information such as an occupation or even their name. Although dementia remains a useful term, the DSM-5 diagnosis was broadened to include the memory impairments known as amnestic disorders. Neurocognitive disorders are diagnosed on the basis of a decline in functioning in at least one of 6 of the following cognitive domains: complex attention, executive function, learning and memory, language, perceptual motor abilities, and social cognition. Complex attention, the ability to attend to sustain multiple or selective aspects of an activity, demonstrated when a person can remain on task, ignore distractions, and divide attention between 2 or more things. Executive function, the ability to plan tasks, make decisions, manipulate information, solve problems based on feedback, apply complex and effortful solutions, and shift between concepts. Learning and memory involves several memory abilities such as short-term recall, delayed recall, cued recall, recognition, and the ability to learn new things. Language involves expressive abilities such as naming, word finding, grammar syntax, and receptive understanding. Perceptual motor abilities, the ability to navigate, use tools or devices, imitate, draw, or copy. Social cognition includes the ability to detect and recognize emotions in others or to understand another person's point of view. The extent of the decline determines whether the neurocognitive disorder is major or mild. Major neurocognitive disorder, the cognitive decline is significant, and the impairments in these areas interfere with independent functioning. Mild neurocognitive disorder is cognitive decline that is modest and independent functioning remains adequate. Major neurocognitive disorder includes all of the following symptoms of dementia: aphasia, the language disturbance that involves impairment in understanding or expressing ideas through language; apraxia, impaired ability to execute motor activities, although motor functioning is intact; agnosia, failure to recognize objects or people that were formerly familiar to the person; disturbances in executive function, impairments in the ability to plan and execute actions. The prevalence of dementia increases rapidly with age. 30% of people 85 years of age and older are affected. It can be quite difficult to distinguish dementia and delirium in the elderly. The 2 disorders can co-occur in the large majority of hospitalized older patients. Many physical conditions are known to cause dementia. Any condition that is associated with physical damage or deterioration of the brain can be involved. Recently, the link between midlife obesity and later dementia has also become apparent. Also called dementia of the Alzheimer's type, DAT, the most common form of dementia, accounts for up to 60% of all cases of dementia. DAT causes a progressive and irreversible dementia that gradually worsens as brain deterioration proceeds, with death typically occurring within 10 years of diagnosis. It rarely develops before age 50, but then increases dramatically with age. 10% of those in their 70s and more than one-fourth in later decades show the disorder. The diagnosis of DAT is made partly by exclusion. In most cases, there are no telltale signs from physical examinations. The insidious onset and slow progression of DAT distinguishes it from other dementias. Memory loss is usually apparent among the earliest symptoms, with increasing degrees of confusion and personality change as more of the brain is involved. Patients undergoing personality changes often initially become distrustful and suspicious, but later may be openly belligerent and delusional. In later stages, patients become totally dependent. The underlying causal condition is a gradual and chronic deterioration of cholinergic neurons that innervate the forebrain. The microtubules within the axons of these neurons begin disintegrating, and tau proteins, which normally stabilize the structure of the neuron, form remnant clumps of material called neurofibrillary tangles. In addition, a sticky plaque consisting of beta amyloid protein fragments and degenerated axon terminals accumulates in deposits called senile plaque, which also damage neurons. There we go. This is what it looks like. This is what a healthy neuron looks like. This is what a diseased neuron looks like. This is how the tau molecules are structured. And this is how it works when you have dementia. Okay. And there you go, shrinkage of the ventricles. The brain just slowly disintegrates. Recent advances in brain imaging and cerebrospinal fluid analyses for early indications of beta amyloid deposition give hope that valid diagnostic markers among living persons may soon be identified. Once upon a time, when I was doing autopsies back in the 1970s, there was no way to diagnose Alzheimer's disease. As a matter of fact, it was rare to get a diagnosis of Alzheimer's disease. It had to be, the only way you could identify it was through autopsy. So people were said to have senile dementia, is what they called it, instead of Alzheimer's disease. But some of the neurocognitive problems that people were facing at that time had rapid onsets, and those individuals were diagnosed a little bit differently. But most people were just diagnosed with senile dementia, what they referred to as senile dementia. The presence of hippocampal atrophy, amyloid, and tau protein levels in the cerebrospinal fluid, and decreased brain glucose metabolism predicted DAT in 100% of the sample. So now at least we have a way to do it. It was like LSD. LSD it's so small, the amount is so small, it's really hard to detect. And so one of the only ways we had of knowing if somebody died with LSD in their system was to do an analysis of their cerebrospinal fluid and see if we could find any LSD in the cerebrospinal fluid. Of course, that happened with autopsy. We never did it on living patients. Alzheimer's disease occurs in both familial and sporadic forms. The familial form is rare with a prevalence of below 1%. This form has onset before age 65 and is most closely associated with presenilin 1 and presenilin 2 genes. There are several known genetic mechanisms that contribute to the sporadic form of DAT, but most cases seem to be associated with the apolipoprotein E site on the chromosome 19. Now, I have a friend whose father died of this type of Alzheimer's disease, and because of it, he was afraid to have children. So when he got married, he married somebody who didn't want to have children, and they still don't have children. But he's in his 70s, and he still doesn't have the disease. So, but he was deathly afraid that he would have it. Now, he has a sister that got married, and she had babies, and one of her children has developed this type of familial Alzheimer's disease. So maybe he was wise in not having children. And there you go. These are the genes. 19. Where's 19? There it is, right there. APOE. Several mutations of beta amyloid precursor gene, APP, on the chromosome 21 have also been linked to Alzheimer's disease. This may explain the relationship between DAT and Down syndrome caused by trisomy of chromosome 21. DAT is almost invariantly present in people with Down syndrome after age 45. It is not yet possible to stop or reverse the course of Alzheimer's disease or its accompanying dementia. Treatment for DAT is focused on techniques to slow the advancement of the deterioration and to improve the quality of life for patients. The acetylcholine depletion might be addressed to use of cholinesterase inhibitors, which slow the breakdown of acetylcholine in the synapse. These drugs can produce modest but measurable effects on cognition, translating into a delayed worsening or, in some cases, temporary slight improvements. Memantine blocks a specific glutamate receptor known as NDMA, produces small benefits but is significantly superior to a placebo. Standard antipsychotic medications and SSRIs may reduce some symptoms but have potentially serious side effects. There may be benefits to nutritional, cognitive, and behavioral strategies to reduce risk of DAT. Aerobic exercise, mental exercise such as puzzle solving, vitamin and nutritional supplements, lowering of cholesterol, and regular but moderate ethanol from wine have all been reported as potentially preventative. None of these strategies have yet accumulated enough supporting evidence to be recommended as effective. Symptoms of dementia in vascular neurocognitive disorder and DAT are essentially identical, except that the onset of the cognitive deficit is usually more abrupt in vascular neurocognitive disorder. Vascular neurocognitive disorder is caused by brain damage that results from the interruption of blood supply to the brain, such as a stroke, which leads to an area of dead tissue, which is known as an infarct. The rate of cognitive decline can be highly variable, sometimes evident in stepwise deterioration in function, followed by a plateau in functioning, since such subsequent stroke adds to the overall damage. It tends to occur more commonly in males than in females. Frontotemporal neurocognitive disorder, and this is what Bruce Willis has, frontotemporal neurocognitive disorder. Includes either a behavioral variant shown by 3 symptoms such as apathy, disinhibition, and compulsive behavior, or a language variant with obvious decline in language ability or social cognition. And he had the language variant. Both variants are linked to distinct atrophy in the frontal and temporal lobes of the brain. The onset is gradual and insidious. Some indication that males are more likely to display the behavioral variant and women more likely to show the language variant. He was making movies and he was having problems delivering his lines, and that's how they discovered that he had frontotemporal neurocognitive disorder. And now he can't speak at all. Major frontotemporal neurocognitive disorders associated with faster decline and shorter survival compared to neurocognitive disorder caused by Alzheimer's disease, but the differentiation of the conditions can be difficult. A variety of degenerative processes may be involved in frontotemporal neurocognitive disorder, including Pick's disease, a progressive neurodegeneration, which typically produces dementia in people in their 50s and 60s. A familial form has been identified, which appears to be linked to genes on chromosome 17. This type of frontotemporal dementia is more common than once thought, accounting perhaps for 1 in 8 cases of dementia. Oh, wait a minute. Pick's disease. There you can see normal aging. This is Alzheimer's disease, and this is Pick's disease. Infection with the human immunodeficiency virus, HIV, produces progressive damages to the central nervous system as the body and brain become increasingly more vulnerable to serious infections or tumors resulting from impaired immune functioning. And that's actually how we discovered HIV. We started seeing people who had infections that we had never seen before. They started developing tumors that were so rare that we'd only seen them a couple times. And that's how we discovered HIV, that HIV was a problem. These people were dying of these really strange infections, tumors and infections that we had seen very rarely before. Also, it also affects brain neurology more directly, causing diffuse cortical and subcortical degeneration. Overall, a small percentage go on to develop dementia. Let me just stop right now and talk to you about the toxins that some people are taking that affect the brain. Anything that affects the brain, any form of intoxication, that includes cannabis, that includes opioids, that especially includes cocaine and the amphetamines, the stimulants, alcohol, of course. All of these things can trigger damage in the brain that may snowball in the future. And a lot of times, if we have individuals that have done something in their past, it has caused a problem in the brain that may become a deadly problem in the future. And we see this all the time. And this is one of the reasons why musicians die in their 50s and 60s from diseases that are from brain diseases that they probably wouldn't have had otherwise. Anybody that uses cocaine or methamphetamines or drinks too much alcohol is probably shortening their lives to some extent. And this is the problem that they will have. It will affect their brain to the extent that they will start developing these problems earlier than they would have had they not used those substances. So despite the fact that you can stop smoking and your body goes back to normal, the damage that you've done to your brain, the micro damage that you've done to your brain, may repeat itself. It may come back and haunt you. My son's fiance has just lost her father because of something that happened to him in Vietnam. And of course, it wasn't even recognized during the Vietnam War. PTSD wasn't recognized during the war. It wasn't until the 1980s that we started using the diagnosis of PTSD. So anything that happens to you, all these multiple concussions or whatever from football players, we're seeing this repeating itself later on. They've been retired for 2 decades, and all of a sudden they come down with with some kind of a neurocognitive impairment that makes them unable to function. Um, Earl Campbell is having that problem. Um, the quarterback for the Chicago Bears, I can't think of his name. He went to BYU. Anyway, he has the same problem. He's got an early onset Alzheimer's disease, probably caused by all the concussions that he had. Newer antiretroviral therapies have produced the incidence of dementia due to HIV disease, have reduced the incidence by up to 50%, and slowed its progress into countries where these drugs are available. That's in the Western world. Unlike dementias linked to Alzheimer's disease or frontotemporal atrophy, a neurocognitive disorder due to HIV infection can have a fluctuating course and even improve. The severity of TBI, that's the brain injury, traumatic brain injury, depends on the location and degree of injury. Usually TBI is not progressive, in contrast to dementias related to diseases or repeated strokes, but repeated head injuries such as those experienced by boxers and football players may produce progressive forms. Also, TBI appears to lower the threshold for other dementias such as DAT in susceptible persons. TBI was provisionally termed post-concussional disorder in the DSM-IV. TBI describes a cognitive impairment that results from a closed head injury severe enough to cause a cerebral concussion in which the brain is subject to mechanical forces such as rotation, acceleration, or deceleration that do not produce structural damage but do cause functional impairments. Difficulties with attention or memory, headache, sleep disturbance, dizziness, fatigue, unprovoked aggression, affective lability or anxiety, personality changes or lack of spontaneity are commonly reported and effects of a series of minor concussions that appear to be cumulative with increasing serious impairments. Closed head injuries such as concussions occur more often in males than in females because males tend to be more active. But as females are entering the realm of these crazy athletic events that we have developed, we may see more of this in the female brain as we see in the male brain. Like football or boxing, or the MMA, multiple martial arts. The more we see women engaging in these activities, the more likely we are to see similar brain damage. If substance-induced cognitive impairments persist after the usual duration of intoxication or withdrawal, substance medication-induced neurocognitive disorder may be diagnosed. The specific types of symptoms depends on the type of substance that is involved. Alcohol may be the most common causative substance. Both dementias and amnestic disorders, which involve memory impairments that affect the ability to learn and recall new information, and terror-grade amnesia, can be substance-induced. The ability to recall previously learned material, retrograde amnesia, may or may not be affected depending on the severity. Those with substance-induced amnestic disorders often perseverate, and we're talking about alcohol here, but cannabis really disrupts your short-term memory, and because of that, people start developing, especially in chronic marijuana usage, and terror-grade amnesia. In other words, they can't accumulate new information. They can't remember new things that they have just learned. So they have a self-induced and terror-grade amnesia. Those with substance-induced amnestic disorders often perseverate. They repeat actions or words. A particularly characteristic symptom symptom is confabulation, in which the amnestic person attempts to fill in gaps of memory by inventing stories or explanations that can seem confused, unplanned, often inconsistent, and sometimes exotic. And this is known as confabulation. It's very common in people who are chronic alcoholics. Confabulation can occur in other memory disturbances as well, but is commonly seen as a component of alcohol-induced amnestic confabulatory neurocognitive disorder. Once established, it continues indefinitely. They don't get better. They just keep doing it. In the case of other substance-induced amnestic conditions, such as those resulting from prolonged heavy use of hypnotics or sedatives, the prognosis may be better. The persisting dementia may improve, and full recovery is often possible. Huntington's disease is inherited through a single dominant gene on short arm of the chromosome 4. Causes irreversible damage to the brain and the basal ganglia. Postmortem analyses typically show circumscribed cerebral atrophy, especially in the temporal and parietal lobes. Parkinson's disease, a slowly progressive neurological degeneration that produces major neurocognitive disorder in up to 75% of affected individuals. Second most common progressive dementia after DAT. Symptoms are related to destruction of dopamine-producing neurons in the basal ganglia. Resulting decreased dopamine activity can be partially counteracted by administration of dopamine precursor L-DOPA. Parkinson's disease, a minority of the patients develop dementia. Degenerative process results in reduction of volume and atrophy in the amygdala and the hippocampus. Besides loss of dopaminergic neurons, other observable brain changes include deterioration of serotonin neurons and widespread Lewy body pathology, abnormal accumulations of proteins in the hippocampus, which correlates with cognitive decline. Creutzfeldt-Jakob disease is a type of spongiform encephalopathy, that is, tiny holes form in the cortex, giving it the appearance of a sponge. It's caused either by slow viruses or by prions, which are abnormal, misshapen proteins. It has been transmitted from cattle to humans in food as mad cow disease. The rare disorder affects men and women equally. Death occurs within 12 months for 90% of the affected patients. Creutzfeldt-Jakob disease, spongiform encephalopathy. Other medical conditions, including vitamin deficiency, hypoxia, and encephalitis, can produce the dementias and amnestic conditions that compromise neurocognitive disorders. A specific form of transient memory disturbance, termed transient global amnesia, describes impaired ability to learn new information before or during a stroke. Other types of transient amnesia may be traced to seizures or reversible metabolic conditions. And that is it. We are finished. Here we go. Here I am again. I'm done. I'm done with this class, and I have to apologize. There was a real serious mess up at the beginning of the semester. We didn't get started right away. That was not my fault. They turned off, Dene College decided that they were going to turn my access to anything Dene College off, and it took them over 2 weeks to get it turned back on. Everybody and their cousin had to sign off on it, as weird as that is. And part of the problem came from the individuals that, and there were a number of faculty members that didn't want to come back. They wanted to teach remotely, and of course that was part of the problem. Those individuals, and I understand there were 6 of us, it kind of made the administration upset, and because of that, they just turned everything off. The other individuals, of course, weren't teaching summer school like I was. So they lumped me in with those other individuals, and that's one of the reasons why It took so long for them to turn it back on because they didn't know the difference between me teaching summer school and these guys. And some of these guys, they left like 3 weeks before the end of the semester. They were fired, in essence, and they didn't actually finish the semester. So that was a little weird. Anyway, this is probably the last class I will teach at Dene College. This and the other 2 classes I'm teaching this semester. I've had a good time teaching at Dene College. I've enjoyed the information that I have accumulated from my friends and colleagues and from my students. Thank you very much for the information. I am an accumulator of information, and I will miss you greatly. Um, who knows, maybe I'll be teaching someplace else. I am kind of old. I am a little bit over the hill. I'm, I am 75 years old, and probably I should just hang up my teaching satchel and ride off into the sunset. Well, but we'll see what happens. Oh, I just got good information. I just got some pleasant information. Last year, I was asked to review Fulbright scholarships. If you know anything about the Fulbright scholarship, it's fairly prestigious. I reviewed proposals last year for the Fulbright institution, and I will be doing it again next year. Or yeah, next year. Well, actually, it's this year. It's in December, so there you go. Good information. I had a great time doing it because my knowledge base is wide. As I just explained to somebody, I'm a jack of all subjects, but a master of only one, and that is psychology, of course. I also have degrees in political science and medicine, English, and what's the other one? One more. Wait a minute. I've got five medicine, English. Maybe I've got dementia. Maybe I shouldn't be doing it. No, I've only got degrees in 4 different subjects: psychology, political science, medicine, and English. Anyway, see you later. Maybe, probably not. You're in Arizona, and I'm in Iowa. So